documentation is really going to be changing a lot in 2023 from what I hear. The EMN codes and having to have so many review of systems and all the note bloat that goes into our documentation. I read some of these notes, and with cut and paste now, they never change over multiple days if you ever read the inpatient ones. But hopefully, what we're going to learn from Jason Adler, now assistant professor at University of Maryland after being out in the community for a while and has made a name for himself with coding and billing and speaking nationally on it, and also consulting all across the nation, will be telling us what to expect in 2023.
Thank you. Am I good? All right. Before I get started, I have to. You talk about these auto-diagnosis lists, and that was a huge win for national ACEP and for emergency medicines across the country in Georgia. And just so you know, it's coming up the Eastern Shore as well. Virginia has an automatic diagnosis list that does include diagnoses such as DKA, status asthmaticus, GI bleed, that if that diagnosis is on the chart, you get paid $15.50. You think it's just Virginia, slipped over to Maryland just last year. This has nothing to do with my talk. You got me all excited. Slipped over to Maryland just last year in August. Optum is the plan benefit administrator for the Medicaid program. And in that case, they said emergency physicians are not qualified practitioners to make a diagnosis involving substance abuse or mental health. Neither are nurse practitioners unless they have a specialty certificate in psychiatry. The only people, in fact, in the state of Maryland, according to Medicaid, the Optum plan, is that those who are in psychiatry or those nurse practitioners with that specialty certificate. But thanks to the work of Dr. Linton and the team and bringing in national ACEP, we fought with the plan over there, and we got emergency medicine on the approved list to treat people with substance abuse. Amazing. That's where we're at. And also, I just was reading up on a MedStar plan, which also is a Medicaid plan that has a restrictive diagnosis list as well. It's actually an auto-pay list. It's a long list. The point is, these things are continuing to happen, and the work of our local chapters of ACEP and national ACEP is really turning the tide in the advocacy work. And thank you, Jillian, and thank you, Bob, for all the work that you do. Moving forward to the future of documentation, I think we start with the past. Let's go back to 1995. That's when our last guidelines came from. But in 1995, historically, we had the launch of Windows 95. It was a brilliant operating system. Jay Leno, Bill Gates, great year. And that's an operating system that had evolved really well over the time, past 27 years. And in the same year of 1995, Tom Hanks won an Oscar for his work on Forrest Gump. But it was a double dip for Tom Hanks because in the same year, he released Apollo 13. And in the 27 years since, Tom Hanks has aged very gracefully. He's aged very gracefully. He's America's dad. Going back to 1995, we were introduced to documentation guidelines. Now, these are a ton of bean counting, expanded, problem-focused, specific words that really, over the course of time, how did it affect us? Like Dr. Bond mentioned, right? We have auto imports into our EMR. The note bloat is increasing. The past medical history goes back to 1972 when you had a bad reaction to a certain medication. Family history, social history, it goes back forever. Our review of systems. We sit at the computer, lurched over, click, 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 click. And we all know EMR time is the biggest source of burnout and fatigue. We don't need it. Unlike the evolution of the Windows platform or the graceful aging of Tom Hanks, these guidelines have not aged well. They have not aged well. But the good news is in 2023, we will have some relief. My name is Jason Adler. Today, we're going to talk about trimming the fat of note bloat and must-know documentation guidelines beginning next year. So we're going to talk about how we got here, major changes to the history and exam section, and understanding the medical decision-making section. So the guidelines that we're talking about will be new to us, but they're not new to the House of Medicine. In fact, they were introduced last year, just over a year ago, in 2021, for the outpatient office visits. These are the entire House of Medicine, anyone that's seen in an office practice. New rules, new guidelines, and part of that involved a unification. Historically, there had been tension between the American Medical Association, which makes the rules, and CMS, which sort of makes the rules or opines on the rules. As of last year, That dynamic tension is resolved because there's complete unification and everything goes back to the AMA and CPT. That will solve a lot of administrative burden moving forward. So my talk today is going to be focused on what I anticipate seeing within 2023, but in full disclosure, the official emergency medicine guidelines have not been released. We have a good idea of what they're going to be, and that's what I'm going to focus on, but we'll know a lot more in the end of July, maybe even into August. Then we've got a few months to prep because January 1, everything flips overnight. Imagine seeing a patient that comes in with low back pain, maybe abdominal pain. Maybe it's the 50-year-old female that Mike Weinstock talked about earlier. And then you look at our exams, right? And by a show of hands or not, how many people have gone to a patient's room to update them on the results of a test, and they tell you, I already have it, right? It's normal now. They can see our information as fast as we put it into the computer. And I always think about the patients reading the chart. As a philosophical approach, you want these charts to stand the test of time. Forget the reimbursement component. I think about risk and for them standing the test of time and communicating information over time. Patients come and go, but these medical records live forever. So you're talking to your patient about the exam that you just wrote, and they're saying, what does normocephalic mean? Oh, you've got a normal shaped head. And I'm here for back pain. Yeah, it's okay. Oh, and you examine my psychiatric, what? Some of these things don't make sense. And of course, there's a discrepancy because we gave a reference of back pain and we see abdominal pain. We could hit the discrepancy in a little bit on the medical decision-making section, but it's a lot of bloat. This adds so much space, and as Vaughn mentioned, it gets repeated over and over and over again, doesn't add much value to anything. So the most important change that we're gonna see January 1, 2023, is that the history and exam are no longer part of leveling the visit, assigning a value to the work that you do for the visit. Now, we're gonna write histories and we're gonna document exams, right? We're gonna do what's appropriate, and according to the guidelines, these are the 2021, the extent of the history or exam is determined by the treating physician reporting the service. In other words, you'll never get another note about a down code, no more 9 review systems where there could have been 10, no more additional note bloat, no more nonsense, really focused on what the treating physician believes is most pertinent and appropriate. And going to Mike's point about what is the patient's question and what is your question, that's what we would document in the HPI, review of systems, PFISH, and physical exam. That's a major, major change. It's a good change. In fact, America's Dad, yes! Yes! I'm excited. All right. So if we're not scoring the exam as it relates to the coding guidelines, and that's a different piece, then really the entire discussion is about medical decision-making. The entire chart will be scored based on medical decision-making. So I've gone through the guidelines that we have, taken the grid, and I don't want to reference scoring and grids. I don't want to show any pictures of grids or numbers. I want to talk about concepts and approach. 4 Ds. It's your differential. What are you doing about it? Who did you discuss it with? And for what is your diagnosis, I could also say, what are the determinants? And I'm talking about social determinants of health and health equity, because that's part of the story now. It's a beautiful thing. Apparently, I'm very excited about social determinants of health, but this computer is not working with me. There we go. There's the 3rd click. It's like when you're working on that pickle jar for 20 minutes and you give it to your 5-year-old who just opens it. So before I go into the 4 Ds of medical decision-making and a philosophical approach to working this out, I want to take a step back and just talk about the medical decision-making section, the concept of thinking in ink, right? And this is what Mike was alluding to and what we talk about often. And when we sit in the emergency department, there is so much parallel processing, right? We're at the computer, we're looking at a lab, we're ordering a medication, an EKG comes in, you get an overhead page. Can anyone please pick up the damn phone? Then you've got this new EKG, and then you got to pick up a chart, go see a patient, then you order another, right? There's a lot of parallel processing happening. And at the same time, there's conscious and subconscious work that we're doing, whether it be interpreting a study and then performing a result. And we need to think about a constructive way to get that on the record so that it shows the work that we're doing in a meaningful way. being purposeful and deliberate about how we make these notes. D1, differentials. So the first thing I'll say is, have you seen these dot phrases like dot, abdominal, male, and it has 30 different diagnoses that like you obviously don't address or think? No, bad. We'll just say bad, and that doesn't work, right? That's not practical. But what you can do is write a differential that relates to the workup that you're actually performing in a meaningful way. And then you want to include your rationale for the diagnoses you're including and also what you're excluding and how you got there. It's thinking unique. It's doing that process and layering comorbidities because that affects the differential. You look at that back pain patient, if it's a 30-year-old male who works in IT, not picking on IT, but he works in IT and is at the desk all day and has non-traumatic low back pain, has a different differential than a patient who is some age, who has a history of IV drug use and has social determinants of health that affect their ability to access care. The differential changes. In fact, just think about fever. I saw the last, I just wanted to find a way to work in this one example. Last shift I worked, we saw a patient with a fever who had HIV with no CD4s, with diarrhea, and had been on a 3-day camping trip. And we were talking about the differential diagnosis with the residents, and everything's on the differential, right? What's not on the differential? And what do we order? What are we thinking about? How do we write this down? I don't know. ID is going to be, they're probably still picking up new tests to order on this patient. But the differential and the comorbidities make a difference in how you approach a lot of these patients. But documenting that makes a difference. In terms of what are you doing, I think about these secondary complaints, right? If there's a chief complaint of fever or chief complaint of back pain, there's always secondary complaints or abnormal vital signs that we are addressing, problems that we're addressing. You're almost thinking of an active problem list that don't always make it to the chart. And there is an opportunity where it does help you. And any electrolyte arrangements, it's just everything that we're addressing. I think a lot of the times we focus on the conscious work that we're doing, and the subconscious work is just, okay, yeah, I see the low lab value of X, I'm going to replace it with Y. But we don't always document that you actively did that and it doesn't get captured. We should think about it in that way. And I just use an example of alcohol intoxication. Very simple MDM. You could add a lot to this, but at its core, patient comes in with altered mental status. CT ordered to exclude ICH. You've just declared a differential. Hypokalemia, hypomagnesemia, repleted intravenously to prevent arrhythmia. That's a secondary problem that you've identified and that you are now addressing. No harm in writing that. Discharge vital signs. Mike hit on that a lot. I'm not going to go any further into it, but the tachycardia improved with IV fluid. You're addressing abnormal vital signs. It's really, really basic stuff. But it gets counted now in a better way than it did in 1995. 27 years ago. Chronic conditions are interesting because we don't always think about them in emergency medicine. And there's a quote from page 13 on the 2021 guidelines that resonates with me. It says, stable for the purpose of categorizing the MDM is defined by the specific goals for the individual patient. And if they're not at their treatment goal, they're not stable, even if they're not having any change in their symptoms. And actually, they give the example later of a patient comes in with hypertension, is medicated, and their pressures are like in the 160 systolic and asymptomatic. By definition, according to the AMA and the new rules, that's an unstable patient. Now, clinically, we know. No one here gets excited. In fact, asymptomatic hypertension is a trigger for most of us, right? Like, I get it. I hear you. But what does it relate to what we do? Well, I would offer that if a patient comes in with an infection and they're diabetic, insulin-dependent diabetic, and they've got hyperglycemia, that's a problem addressed. If you're giving fluids and that's helping treat the hyperglycemia, you're taking account of all the problems that you're addressing. What are you doing? And you document that in a way that shows that you're caring for the entire patient. This is a key point number 2, changes from 95 to 2023. In the past, the guidelines we benefited and promoted ordering tests, images, and tracings. You got points for that. Well, we all know, just looking at CTs, for example, ordering more is not better. There's cost to the patient and the system. There's cost to the patient in terms of health and radiation. There's value is quality over cost. And we'll just say that ordering a ton of CTs is bad value for everybody involved. In the new guidelines, 95, 2023, you get credited for either ordering the test, that's still there, but if you don't order the test and document your rationale as to why, you get credited the same way. You're not being penalized for not ordering a test. So I really didn't coordinate with Mike, but we have a lot of the, like I just happen to pick on PERC rule and PCARN and Nexus, but PERC negative, no indication for CT to rule out PE, right? That's a statement that would be made where you would get credited in a way that's good for the patient, supports your medical decision making, it shows what you're doing. There will be a higher emphasis on independently interpreted procedures, things like X-rays, ultrasounds, and EKGs as we move forward. It's a little bit deeper, and I feel a little truncated with the time right now. I don't want to go too much into this, but you will be hearing about this more and more throughout the year, that there were certain procedures that historically were billed that may not be billed, and either which way, if we are doing the work, the cognitive work of interpreting procedures, these ultrasounds, right, or the EKGs, we want to document that appropriately, and then the description would be I independently reviewed, and my interpretation is. That's the difference between a review of report and your independent interpretation. A review of report is what I see a lot in some cases, where you literally cut and paste what the radiologist says and then put it down. All you're doing is shifting the same information somewhere else. Save the note bloat space and your time with that. Either make an interpretation yourself, declare it as your own, or just let the radiologist or cardiologist read stand on its own. And if you're doing the EKGs on your own, then you already have it there. We went through diagnosis, doing, and then discussions. So this topic is really, to me, about charts standing the test of time. Because patients come and patients go, and you want 5 years later for a physician who picks up that chart to understand what happened. If something bad happens, you want to make sure you can defend yourself. And if a patient reads it, it should make sense. We get information from a ton of different sources. From family members, if a referral comes inward. If you have a discussion with consultant, there's a lot of risk management implications with the discussion with consultants. Old record reviews. I see a lot of charts that have long paragraphs that incorporate all this information, but it doesn't say per EMS, or old record reviewed colon, or this consultant said this. And we want to delineate that to make a clear record of who said what information was obtained from what source. That will shift the way some of these charts get coded. And while this has nothing to do with the documentation guidelines, continued reassessments with the patient really offer a ton of value. It shows your engagement. Again, I just think about the patient reading the chart. Sometimes you get complaints that the doctor never saw me or never spent time with me. You have 3 assessments that are time-stamped. That supports that. It's just good patient care. We want to get away from the EMR, and we want to get at the bedside. The more reassessments we do, the better off we are. And in fact, every reassessment, you build that bond with that patient, which we know decreases malpractice risk. Social determinants of health. We're talking about health equity, and this is the 3rd biggest change from 1995 to 2023. So if I were to say to you, what's the word association you would have if I were to say ICD-10 or diagnosis? And I think most people would say billing. Yeah, okay. So ICD-10, that code sets of diagnoses are trademarked by the World Health Organization. The intent of that code set is to track epidemiologic illness and injury across the world. It's epidemiologic tracking, it's data aggregation. Can you think of something over the past 2 years where data tracking would be helpful for illness? All of the COVID data that we have comes through these claims forms. It's not about the billing, it's about data tracking. And social determinants of health are critical because it involves health equity. And we know that there are patients that we see every day. Emergency medicine is the safety net of our healthcare system. And there are patients that we see every day that have these social determinants of health and have lack of access to care, high quality care, follow-up care. Just think about the patients you give the antibiotic to go pack to, the inhaler, because they're not going to go to the pharmacy and spend $300 for the CFC albuterol inhaler they don't have access to or don't have the money for, and they're so expensive, or the insulin, things like that. It's critical to get that on the record, because what we're really doing is tracking And that could really shift national policy, regional policy, and now even to the ground level of your chart. Your chart will get credited with these new guidelines. It's part of the medical decision making. It's part of the medical decision making. And the pivot is not insignificant. In fact, in the 95 guidelines, you were credited with points if you gave IV narcotics. That's a fact. You are credited on the risk table for giving IV narcotics. Now, 2023, you are credited with acknowledging that there are social determinants of health. And you drop this down in the diagnosis line, and these diagnoses are not, there's lots of lists out there, happy to share them with you, but it's what we see very often. We see patients that lack adequate housing. We see patients that have problems related to economic circumstance or living in residential institutions. And the more you can get that on the diagnosis line, the more that data gets aggregated, flows up from your chart, from the hospital, to the system, to the state, to the nation, in a way that will show visibility to the work that's being done in your department. This is a good thing. Health equity is a very important topic, and we're moving in the right direction. And I bring this all up to just tie it all together with this quote on page 13. Multiple problems of a lower severity may in aggregate create a higher risk due to their interaction. Comes right from the guidelines. Combining all this stuff together shows the complexity of the care that you provide every single day to our patients. It's not just back pain. It's complicated. It's never easy, right? It's never easy. So I'm going to pause there. I have one slide after it. I'll open up to questions. I'll just say how far off. I feel like I'm feeling about 18 minutes in time. Oh,
Any questions?
maybe 19 minutes.
So you mentioned getting points for, not doing imaging so long as we've explained it. In those settings, I mean, certainly for me, if I see someone put, PERC score equals 0, I know that we don't need to do a CT scan for PE. Is that going to be sufficient, or do we actually need that kind of language around saying PERC score is 0, and that's why I'm not doing a CT for this patient?
Yeah, I spent a lot of time thinking.
How spelled out do we have to do that?
I spent a lot of time thinking about how I would frame that. So it depends on who's coding your charts. I think those organizations that are familiar with emergency medicine and know PERC negative means CT was considered can support giving you those points. Those that want everything tied up in a nice little bow may not be comfortable with that. And the truth is, we'll know more information once everything is released, if we might get some clarity on that coming down in July, August. But I think there will be variation on how that's executed. It's a great question.
Hey, Jason, sorry. My question is very similar to David's, and you sort of answered it. But if a patient comes in, so in terms of like me writing the diagnosis in the end, the patient has an already established diagnosis of, let's say, hypertension, but they didn't come in for that. Do I still write that in my chart as a final diagnosis?
Yeah, it's helpful if it's something you address or deliberately don't address and describe your rationale why. I think the topic about making diagnosis in emergency medicine is very, it's commonly discussed now because of all these automatic diagnosis lists. And generally speaking, if it's a simple, non-complicated diagnosis, one diagnosis doesn't always work for a number of different reasons. Now, we know it's illegal. We know we have prudent layperson standard, which, by the way, was written by Senator Cardin from the great state of Maryland. In Maryland, we do crab cakes and prudent layperson. But for whatever reason, these insurance companies are giving us a hard time, so the best practice would be to write the diagnosis lines in ways of problems that add the complexity to the visit of things that you consider. So for example, you see a chest pain patient, their heart score is 4. It would be chest pain of moderate risk for cardiac etiology, 1, abnormal EKG, number 2, history of diabetes, number 3, active nicotine use, number 4. That gives a nice, clear descriptor of the work that you did in a way that would communicate it well for the epidemiologic tracking.
Hi, you mentioned treatment goals as a marker of stability. Is that based on the provider or the patient's treatment goals? For instance, my lady with a headache that's 20 out of 10, her goal is to get it down to 0. Realistically, it's probably not going to go that far.
Yeah, it's a great question. So treatment goals is referring to chronic conditions, and it's chronic conditions which generally are up to a year. So it wouldn't be on a case-by-case basis. What we're talking about is previously diagnosed things like hypertension, diabetes, where they are treated, or are in the process of being treated and not based on the current standards of what would be their target. So in hypertension, based on JNC or diabetic control, A1C. Correct. It's chronic conditions. Yeah, I'm sorry about that. All right. I appreciate everybody's time. Am I muted?